So, 86 patients were enrolled in multiple sites in the US, and these are patients receiving hemodialysis 3 times a week. They have to have a history of hyperphosphatemia, so obviously they have to have a need for a phosphate binder. Their phosphate in the prior labs need to be between 4 and 7. Um, as you know, our goal of therapy for patients on dialysis is to try to accomplish as close to a normal phosphorus as we can, but we're at least trying to achieve a 5.5 milligram per deciliter or less. So 5.5 being your goal of therapy. So this patient's already taking a phosphate binder that had been prescribed by their treating physicians, had a baseline value between 4 and 7 with an average of 6.2, I believe, at entry. And so, yeah, 6.2 milligrams per deciliter at entry. So these patients that were already above 5.5 were invited to go straight into the titration, where they would start the study medication, OLC, add an initial dose of 500 milligrams 3 times a day. As we discussed, 500 milligrams is a small tablet, very compact, easy to swallow. And then those patients that were not at 5.5 already were put into what's called a washout, where we actually tell them to stop their previous binders, and then we watch their phosphorus level to see if it gets over 5.5. When it did, then those patients were started on the treatment for those 6 weeks. And at the end of the titration period, um, that consisted of either 6 weeks or the time it took the patients to reach a level of below 5.5 milligrams per deciliter. So some patients took a couple of weeks, some patients took the whole titration period. They moved into a maintenance period. So we wanted to see, once we got you to below 5.5 milligrams per deciliter, how you did over time on a stable dose. And so those was the observation period of 4 weeks. So what was very remarkable is that the uh, at the beginning of the trial, um, the number of patients that had a phosphate of less than 5.5 were 59%, despite phosphate binder treatment. And so, contrary, 41% were over 5.5, despite physicians and the patient best effort. Contrast this to 90% at the end of the treatment with OLC, uh, obviously versus 10% that did not accomplish treatment. So we had a significant increase in the number of patients that reached their treatment goal. This is not trivial. I've done multiple studies with phosphate binders in the past. I had never seen a drug perform this way. And it's really remarkable. It's a small study, I understand, but finding this kind of efficacy, it's unheard of. And I think it relates to the patients being able to get to that number, taking just a small number of tablets. 54% of our patients in this trial were taking just one tablet 3 times a day with meals, or 1,500 milligrams. 14% were taking just 2 tablets. So about 69% of the patients were taking 3 or less tablets per day. So as we discussed pill burden earlier, we went from an average of 6 tablets a day for their existing binders to 3 or less. So significant reduction in the number of pills. Very few patients discontinued the medication due to adverse events. Those that did were related to diarrhea or vomiting. A significant number of those events came from a portion of the study that studied a higher dose where we're trying to see how much of this drug can be absorbed if you take a higher dose. So um, that was a little nuance of the study that would not be part of clinical practice, where we normally do not start our patients on very high doses from the beginning. As you might imagine, we titrate slowly and make sure that we have the best phosphate binding effect with the least number of complications. Um, Further to this, um, the um, patients that were adherent to treatment were 58%. This is per their own recollection at the beginning, versus 70% saying, yes, I'm taking the pills when they at the end of the study. And very interesting again, 79% preferred OLC versus their previous phosphate binder, and 98% agreed the drug was easy to take. So that's a significant um, improvement, and 89% were satisfied with OLC versus 49% with the original binder. So importantly, um, when you talk about efficacy, meaning how well are you able to accomplish what you're trying to set up to do, which is to get our patient's phosphate binder, phosphate level to below 5.5. There are several things that affect how you can get that done. One is the potency. How well does the medication work in binding the phosphate from the intestine, right? But a very, very potent drug that you cannot take doesn't work. If it sits on the counter on your table, then the efficacy is zero. It just didn't do anything, right? So you need to have something that's potent that the patients can take. So it relates to that pill burden, availability, and accessibility. So if the patient can take it, they tolerate it, and it works, then you get the efficacy that you need. And I think all this, in the case of LC, lined up to result in an efficacy of 90% of patients controlled at the end of the study. Uh, The, the pessimists say, well, 10% didn't get control. Okay, well, that's an improvement over 50% traditionally. And we understand that, customizing treatments for patient needs is going to still be a part of what we do. And luckily, there are many other options available. None of the drugs in the market will disappear, but having a better option will allow us to treat more patients better. Yeah, I think again, you touched on the online surveys before. Um, the, there's something that we cannot. Um, the 63% in the small study that Unicycle did say they forget. The forgetfulness is not just oh, I forgot to take it, is related to you forgetting to do something that you dislike, right? So, yeah, I forgot to go to the gym today. Well, you didn't forget to go to the gym. You feel it as a burn and you go, I just didn't go. I'm going to tell people I forgot. So that forgetfulness may get better when what you're trying to do is not a burden, right? So I think a significant portion of I forgot is I just didn't want to do it because I get nauseous. It's a big pill. It has to be chewed. It gives me stomach pain. It tastes poorly. It stains my teeth. So I'm just going to choose to forget it. So, um, I know for the audience, this survey found that 63% of the patients found that they just forget to take the phosphate binder, and the 47% said that the significant number of pills they need to take was a burden, and the large pill size was a burden. So if you decrease the pill numbers and decrease the pill size, and they're no longer difficult to carry, maybe we make it easier for them not to forget, and give increase that efficacy that we discussed. When a colleague says a famous little thing about phosphate binder, the best phosphate binder is the one our patients take. If they don't take it, it doesn't work. So we make it simpler for them and they will take it and it will work.